What is this logo there? CMAAO?
Sir, an webinar is going to be conducted. So this is a logo for that.
I see.
Advertisements are going on. So that is a logo for that.
Okay, okay.
So it's sharp 7. So with all your due permission, can we begin?
Yes. Yes.
Thank you so much, sir. Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. Sir needs no introduction, but it's my pleasure and honor to introduce him at our platform. He is none other than a famous ophthalmologist, Dr. Quresh B. Muscati, sir. Sir is MS, DOMS, FCPS, FICS, consultant ophthalmologist at Muscati Eye Clinic, Mumbai. With the help of sir, we'll be taking a close look on today's topic, which is management of red eye. Before moving on to today's session, let us have a brief look on what the topic says. Red eye is a common condition that can be caused by various factors, including infection, inflammation, trauma, or allergies. The management of red eye involves a comprehensive approach to identify and treat the underlying cause of the condition and alleviate the symptoms. Now, with the help of sir, we'll be taking a brief look about the topic. So now, without any further delay, I would like to welcome sir at our forum and would like to hand over the session to him for his talk to begin. So over to you.
Thank you, Batul, and welcome all the viewers who are with us. This is a very simple issue. Most patients with a red eye will approach their nearest doctor, not necessarily the family doctor, not necessarily the eye doctor, but could even be the family doctor. And very often he is faced with a diagnostic dilemma as to what exactly is this red eye. Some of these are harmful conditions, some are harmless conditions. So let us see if we can, as we go along, see what the various conditions which can cause red eye and how we can tackle them. So the first, just one moment.
Sure, sir.
Yeah. So first, let us go to something which looks very scary, but is a harmless condition. That is subconjunctival hemorrhage, hemorrhage under the conjunctiva. So it could be because of trauma, like the picture you see with a dark crimson red blood. This man banged his head, face into a door. And there is a lot of blood collection over there, very, very dark red. Patient is quite comfortable. Only if the cornea is abraded, if there is an abrasion of the cornea, will the patient be uncomfortable. Otherwise, irrespective of the amount of blood, he is quite comfortable. His relatives say, "My God, what has happened to your eye?" But he is comfortable. So there are no symptoms virtually. All you have to see is ask him to elevate his eye and see that the lowest bottom rim of that red hemorrhage, you can still see as clear. So if there is a part which is seen clear, then it is only a subconjunctival hemorrhage. The only harmful condition in this is sometimes there is a head injury. And with a head injury, the blood trickles from the brain to the eye. In that case, the lower edge of that hemorrhage will not be seen. So if the edge of the hemorrhage is seen, you can tell him rest assured. You don't have to give anything. If you want to give something, you can give vitamin C tablets. No need for any eye drops. It takes about 10 to 15 days for the hemorrhage to get absorbed. Sometimes it could be crimson like this. Sometimes it could be orangish red, as you can see in the middle picture, where you can see the other part of the eye is white. So it's just a blood clot which can be without an injury. Even just blinking of the eyes during sleep can cause this. Small fluctuations of blood pressure can cause it. Rubbing of the eye a little bit can cause this hemorrhage. So it is totally innocuous or harmless. And no matter how scary the eye looks, the lower picture of the face that I've shown you is because of a fist injury. So there is a blood clot in the lids as well. And there is a blood clot in the eye as well. But the eye is quite safe. So it takes 10-15 days to disappear with or without treatment. If the patient is anxious, you can give him some tear drops to put in the eye as a placebo effect. Let us move on to allergy. Now, allergy can affect usually young adults from the age of 5 to about 18, 19. By that time, the allergy sort of weans off. In this, you'll get redness in the eye, and you'll get these white spots around the limbus. Limbus is the part which is where the white meets the black. So you'll get these white spots. This is called allergic conjunctivitis, which is bulbar. Bulbar means it is affecting the visible part of the eye, what you can see. If sometimes it is bulbar, sometimes it is palpable. You see in the picture on the first picture where I've everted the lid, and you get these large follicles in the lid, and this is the large papillae in the lid, like these, like cobblestones in the eyelid. So this is called palpable variety of allergic conjunctivitis. So you can get palpable, or you can get bulbar variety of allergy. Then we'll talk about how to deal with these, but I'm just giving you differences in appearance, how it looks. This is common conjunctivitis. The picture on the left, which is the light pink one, is borrowed from my father, which is about 60 years old, this picture. So the quality is not so good, but conjunctivitis has not changed, and its management has not changed since the last 60 years. Almost 80% are viral. You see the gentleman down there with his face seen? Viral conjunctivitis typically comes as an epidemic and affects both the eyes, one after the other. The discharge is very thin, watery discharge. While if it is bacterial conjunctivitis, as you can see in the picture above, you can get a greenish, yellowish, thickish discharge. That is more of a bacterial or even a fungal conjunctivitis, which is not very common. The redness is more in the periphery of the eye, but around the limbus, where the black meets the white, there is not much of congestion. So congestion more in the periphery, discharge which is watery, which is viral, or a thickish like pus, which is bacterial or fungal, characterizes conjunctivitis. And the third type of where you have to distinguish is a dry eye. When the eye is dry, especially in our computer programmers, in those who blink less, you can see the eye is supposed to blink 30 to 35 times a minute. And in computer programmers or those stuck to their mobile phones for WhatsApp or whatever, the blink goes to half that rate. So when the eye doesn't blink well, the eye gets a little sore, and you can get redness, not too much of redness, but a mild redness, persistent redness may be there. And we find out many times it is associated with blepharitis. You can see the top right picture, the squamous blepharitis. It is like a dandruff of the eyelashes. When you look at something like this, look for this. And the meibomian glands, the oil glands of the lids, can also be affected, and you can get a little cheesy material coming out, like toothpaste material coming out, which is called MGD or meibomian gland disease. If the dryness persists, then the dead cells of the cornea, which are washed away by the tears, remain there, and you can see filaments. Sometimes you can see mucus at the canthus. That means that the edge is just some amount of mucus because it's not been washed away. It's like the kachra which is not washed away by the municipal workers in the drain. And we use various tests to find out the dryness. We put a paper in the eye and see how much it gets wet in 5 minutes. That's called the Shermer's test. Or we have various stains like rose Bengal, by which we stain the area. And if it's dry, you get this staining. And sometimes we keep the eye open artificially for 10 seconds and see when a dry spot appears on the cornea. That's called the breakup time, when the tears break up. So these are some of the tests we do for dry eye. So whenever you're faced sometimes with a diagnostic dilemma, especially amongst family physicians, people tend to use aggressive steroid therapy. Not so much family physicians as even the chemists, when the patient goes with a little red eye, they give them steroid. This suppresses the symptoms. So whether it is due to allergy or dry eye or for infections, it suppresses the symptoms, but sometimes results in fungus and sometimes results in cornea getting involved. So avoid aggressive steroid therapy and avoid shotgun therapy with multiple anti-infective agents. Some doctors put antifungal, antiviral, antibiotics all together. And then you get a reaction, a drug reaction, a condition called conjunctivitis medicamentosa, where there is a little bit of edema of the conjunctiva and a pale redness. which you can see. This is because of too much of drops which have gone into the eye. So this is called, if the cornea is affected, it's called keratitis medicamentosa. If only the conjunctiva is affected, it's called conjunctivitis medicamentosa. So I normally find that I ask the patient, when I suspect this, what have you put in the eye? And he comes out with 20, 25 different drops over the last 5 days or 7 days. So let us go take each one at a time. Allergic conjunctivitis, there are various names to it. Atopic, if even the skin is involved, or vernal, which occurs not during the spring or summer months, or perennial if it is all the time, or seasonal if it is according to season. As I told you, it could be palpable if it's in the upper or the lower eyelid, or it could be bulbar, or sometimes if the palpable rubs against the cornea, then you can get what is called a shield ulcer, ulcer on the cornea, as you can see in the lower right picture. So usually diagnosis is quite simple because patient comes with history of itching with or without additional symptoms like redness, photophobia, watering, foreign body sensation. Or on examination, you see papillae on the lid eversion or around the limbus, and you may see a shield ulcer. So diagnosis is not difficult. These are some more pictures, the palpable variety, the bulbar variety, and the shield ulcer that you can see. So what are the treatment options? Allergy to something. So we need to find out what it is, usually pollen or the grass or some food item. Is very difficult to find out. And if you can find out, you can avoid the person exposure to the antigen, but it's often impractical. Simple thing that we can advise is improving hygiene, because when the children get this allergy with dirty fingers, they rub their eyes, and that can cause infection. So tell children who are rubbing their eyes not to rub their eyes, give them some glasses to wear, and ask them to wash their hands frequently, like we used to advise in COVID time. Sunglasses is very good for when they go outdoors because they will put their fingers into the eye less. And simple ice compresses or cold compresses. Nowadays you get cold masks which you can simply put in the refrigerator, take it out and wear it on. Sometimes there is dryness in the eye at the same time. So if the patient complains of sandy or burning sensation along with the itching, then you must treat with the teardrops as well. Otherwise, the normal treatment is with anti-allergic drops, which are called mast cell stabilizers and antihistaminics. And now we use drugs which can do both. For very severe cases, we use topical cyclosporin, like orosporin or taclimet, and we avoid steroids as much as possible. So the newer drugs are mast cell stabilizers, like ketotifen, ketorolac, olopatadine is another potent drug which is both a mast cell stabilizer and an H1 blocker or antihistaminic. And there are some new kids on the block like bipotestin and alcaftidine, which is just twice a day or once a day, and very, very effective drugs. So earlier, most people used to treat with steroids with all the side effects of steroids. We tell you to avoid steroids as far as possible. We use steroids only in refractory or very severe cases, always as a supplemental therapy, maybe 4 to 6 times a day for the first 3-4 days with very rapid tapering, and milder steroids which will not raise the intraocular pressure. And we monitor the compliance, and we tell them to throw away the steroids after a few days. And at the same time, we start the other mast cell stabilizer drops so that those take effect and then the steroids are not required. And we counsel the patients on ill effects of steroids and scare them a little bit. Moving on from allergy to dry eye, the commonest causes of dry eye are what I call the ABCDE. As we age, the more chances that the tear production drops down. So A is for aging. B is for blinking. We blink less when we stare at a computer screen or a mobile. We must encourage patients, young patients especially, who are on the screen for 8 to 10 hours a day, to blink more often. Every few minutes they must voluntarily blink, and every 30 minutes they must close their eyes for about half a minute or a minute or so. So B is for blinking. C is for contact lenses. Those who wear contact lenses, there is an additional surface from which the tears can evaporate. D is for drugs. very many drugs like antidepressants, antihypertensives, anti-diabetic drugs, antacids which we take for acidity, antihistaminics which we take for colds. All these as a side effect can produce the dryness in the eye. So we need to ask patients history of what drugs they're using. We don't stop the drugs, but we know that we need to supplement with teardrops. And E is environment. In a city like Mumbai, which is highly polluted, a lot of patients get dryness because of the environment. If you're working in a chemical factory, you're more prone to it. If you're working at high altitudes where the air is very dry, you're more prone to dryness. So A, B, C, D, E of dry eye is something which all family physicians can ask every patient. You simply need to use your ears to suspect dry eye even before you use your eyes. I showed you some pictures of dry eye with meibomitis or squamous blepharitis or some mucus on the sides. But use your ears, talk to them about the A, B, C, D, E, and in most cases, investigations will be quite unnecessary. So management of dry eye, we aim to improve the tear film and alleviate the ocular discomfort. And we always look for MGD or meibomian gland disease and blepharitis. If it is there, we need to treat this at the same time. Otherwise, just giving tear substitutes will not help. So there was a dry eye workshop on 150 dry eye experts sat down and proposed a 4-step management algorithm of dry eye. We won't go into all those details. Basically, it means we have to replace the tears by giving aqueous supplements. So we give tear drops from outside. If there is lipid deficiency, nowadays we have sophisticated tests by which our tears is composed of a mucin component, a lipid component, and an aqueous component. So depending on which one of them is missing, we can supplement with the appropriate artificial tears. In severe cases, we occlude the puncti. Both our upper lid and lower lid contain punctum through which the tears flow out. So if the tears are less, we close those puncti temporarily or permanently so that the tears will remain in the eye for longer period. And you can also have tight fitting glasses with side protection, which is called moisture chamber spectacles. They retain your own tears in the eye for a little longer time. Then you have tear stimulation. There is some tablets which are rich in omega-3 fatty acids or diets which are rich in omega-3 fatty acids, which help to produce better quality tears. And you have oral pilocarpine tablets. These are in severe cases, 5 milligram tablet twice or thrice a day, which can stimulate the tear production. And we have found that stimulating the nose by an instrument can also result in tear production as a reflex thing. So we have gadgets which actually stimulate the nose. This is quite new, just about a year old. Let us move on to something more bhayanak, more scary, and that is red eye due to infections and inflammation. So we first, to summarize, we talked about the subconjunctival hemorrhage, which you said is most cases is harmless. Then we talked about the 3 common causes, which is allergy, dry eye, and we talked about the computer vision syndrome and other things. Now we are talking about red eye due to infections and inflammations. So you can have bacterial conjunctivitis, you can have bacterial keratitis, you can have sclera involved. So if conjunctiva is involved by infection, we call it conjunctivitis. If the cornea is involved, we call it keratitis. Also other words for it, a corneal ulcer or a corneal abscess. Just like an abscess anywhere in the body, you can see this picture is of a corneal abscess. If the sclera is involved by infection, we call it infective scleritis. Sometimes you can get non-infective because of immune reactions or inflammations, keratitis, scleritis. And if the inside of the eye is involved, that is the iris or the ciliary body, we call it uveitis. We'll see some images of these. So what are the common bacteria that affect the eye? There is gram-positive cocci like staph, strepto, and pneumo. There is gram-negative cocci and coccobacilli like moraxella or gonorrhea. Gram-negative rods like Klebsiella, Proteus, Pseudomonas. These are quite scary. And we get atypical mycobacteria, not the ones which cause tuberculosis, but Mycobacteria chiloni, Mycobacterium fortuatum, M. leprae, which is leprosy. You get these, usually these are post-operatively. After a cataract surgery, when the resistance of the eye is low, you can get infection, or after a LASIK surgery, post-operative infection you get with mycobacteria or with Pseudomonas. These are some of the common organisms. Why do all of us not get infections so often? Because we have multiple built-in mechanisms, protective mechanisms. One of them is our eyelids. We blink so often, I told you 30 times, 35 times a minute. So anytime a foreign body is approaching us or something is approaching and we can see it, we immediately close our eyes. So our eyelids are our biggest protectors. Then we have the tear film. I told you the tear film has got multiple layers. We've got the aqueous layer, which is 80% of the tears. It washes the eye. So any bacteria, germs coming into the eye are washed away, and they pass through the puncti, through lacrimal passages into the back of the nose and the throat. And we've got mucin or sticky material in the tears. It traps the bacteria and prevents them from progressing. And our tears also contain some enzymes called lysozymes, which destroy the bacteria. So our tear film is the second protective mechanism. Then our conjunctiva itself contains lymphoid tissue, subepithelial mucosal lymphoid tissue, also known as MALT. So that can produce enzymes to destroy the germs. And the very fact that our cornea has got an intact epithelial layer, most organisms cannot penetrate the intact epithelial layer. So unless there is an abrasion, you had a road traffic accident and your cornea upper layers are gone, then infection can go in. But the intact corneal epithelial layer is protective. And just like gundas or thugs sometimes guard you, similarly, we have normal bacterial flora which are friendly to our eyes, which prevent the harmful bacteria from coming in. So we have got guards inbuilt. So these are multiple protective mechanisms. So why do we get it? Many times we abuse topical antibiotics. That the slightest red eye, we assume it is infection, and we use topical antibiotics. So topical antibiotics lowers the resistance of the eye to fungus and to other things. And the eye becomes resistant to those antibiotics. So we should not use antibiotics unless it is under medical advice. And second is abuse of topical steroids. It acts as a local immunosuppressive, prevents polymorphonucleoside migration, and causes a rebound inflammation and stoppage. So for allergy and other things, we should avoid abuse of topical steroids. The other thing is, if the patient's eye is compromised, like patients has HIV, AIDS, or malnutrition, immunocompromised people, drug addicts, pregnancy, our resistance is low, malignancy, old age, these are some of the risk factors for infection. Minor trauma to the epithelium. This is a fluorescein stained cornea that you can see there, which has large abrasion is stained in green. Abuse of contact lenses, not contact lenses, but abuse. You're supposed to wear the contact lens not more than 8 to 10 hours. People wear it for 16 and 18 hours. The eye becomes dry and it gets prone to infection. And the surface of the contact lens gets protein debris, which acts as a good place for bacteria to thrive. And the other one is iatrogenic by eye surgeons following a corneal surgery or even a cataract surgery. This is a corneal graft done elsewhere which has got an infection there. So sometimes you can get these because of iatrogenic causes. So what are the clinical features of eye infection, severe infection? Pain, redness, watering, lot of discharge, as you can see in the upper right, upper left slide. If there's too much discharge, you suspect gonococcus, pneumococcus, or hemophilus. Some debris in the tear film, lid edema and chemosis, you suspect. Hypopion, you can see that a fluid level in the anterior chamber, and you can even see a corneal ulcer or abscesses. From cornea, you can get, from the cornea, infection can spread to the sclera, but you can get infection in the sclera itself. You can get both infective scleritis and non-infective scleritis. If it is non-infective, it can suggest a very life-threatening disease like polyarthritis nodosa, Wegener's disease, in which the life expectancy becomes less than 5 years after they get this. So they need the treatment in association with a rheumatologist, and many times they give immunosuppressive agents. So you can see here this cornea is quite clear. In the upper pictures, granulomatous scleritis, there are granulomas which are there, multiple yellow spots that you can see. It could be nodular, just a single nodule, scleritis. And sometimes the sclera melts away, called, as you can see, the whole sclera is melted and the inner lining is seen. The ciliary body, the choroid is seen there. Or necrotizing scleritis, the sclera gets completely necrosed. So these are very severe conditions, usually immune origin in rheumatoid arthritis and many of the other systemic conditions. Then we have iridocyclitis. Iris is the brown portion of the eye. In the white skin individuals, it can be blue, green, but usually we have brown, shades of brown, dark brown, light brown. Center, there is an opening in the iris, which is called the pupil. So if the iris is inflamed, you'll find that the pattern of the iris, you can see in the lower right, the iris has got a pattern. So the pattern of the iris becomes lost because it becomes edematous. And you get redness just around the limbus. As you can see in the lower right slide, there is redness around the limbus. It's called circumciliary congestion or redness, congestion around the limbus, unlike in conjunctivitis where the redness was far away from the limbus. And if you see with a good torch, of course, we use a slit lamp to see, but you can see the aqueous humor, the space between the cornea and the iris is turbid. As you can see on the slit lamp picture over there, the little particles which are floating around, these are called keratic precipitates. And that the space in the aqueous is called an aqueous flare that we see. All this we see on slit lamp, but you can also suspect it. And these patients need to be referred to an eye doctor who will treat them with steroids and may lower the eye pressure as well. These are some examples of chronic iridocyclitis. You can see the keratic precipitates, if you can see in the pictures in the lower part, like a triangular formation, and the pupil sometimes gets stuck to the lens. Those are called posterior synechiae. If the pupil gets stuck to the lens, if it gets stuck to the cornea in front, it's called anterior synechiae. And if it gets so badly stuck, the aqueous humor cannot flow out, then the pressure in the eye can rise and you can get a secondary glaucoma. To summarize, we have talked about subconjunctival hemorrhage, which is a harmless condition. We've talked about common conditions, which is bacterial or viral infections, conjunctivitis, allergy, and dry eye, and how to distinguish between them. We've talked about the dangers of over-medicating, getting conjunctivitis or keratitis, medicamentosa. Then we've come to more the dangerous conditions like bacterial keratitis or corneal ulcers, and affections of the other layers of the eye, which will also give red eye. Scleritis in its various forms, and iridocyclitis. All of these can give rise to redness of the eye. One which I have not touched upon is an acute congestive attack of glaucoma, but there it's a very painful condition. Patient will be vomiting, will come holding his eye because of the severe pain. The pressure, which is normally 20, may rise to 60 or 70. So these patients will have circumciliary congestion or around the limbus, and they need immediate referral to the eye doctor. We'll put them on IV mannitol, bring the pressure down, and then do some treatment for them. So I thank you so much for your attention. I will stop screen share so that we can answer some questions. Thank you so much.
Thank you so much, sir. Thank you for your wonderful inputs on the topic that you have shared with our viewers. We hope that all our viewers would definitely gain the knowledge that they were here for. We have received few questions from the participants. I would like to put it across to you.
Yes, sure.
The first question is, which clinical findings suggest blepharitis etiology for red eye?
Yes. So we have to look at again, this is something which even family physicians can do. Just keep a good torch with you. Ask the patient to close his eyes and look at the eyelashes, where the eyelashes come out from the lid. And around the eyelashes, you'll find some dirt, some debris. If it is like dandruff particles, then it is called squamous blepharitis. And then after you ask the patient to open his eyes, pull the lower lid down and gently press the lower lid. If you get some cheesy material coming out from the lid margin, which it should not come out, that is meibomian gland disease. And the lids will be inflamed and edematous. That is called meibomian gland disease. So the two types of lid affections, one is MGD or meibomian gland disease, and the other is blepharitis, squamous blepharitis. They are treated differently. The meibomian gland disease is given a long-term treatment with doxycycline orally for about couple of months, and you can give hot compresses to squeeze out the secretion of the oil, excessive oil from the lid margins. While if it is a squamous blepharitis, then you use the lid cleansers or lid wipes, just soap and water type of solutions to clean well and use any anti-dandruff shampoo, dilute it and clean the eyelashes well. Thank you.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the question is, what is the role of subconjunctival hematoma in the etiology for red eye?
The first slide, perhaps the gentleman or person came in late. The first slides that I showed was subconjunctival hemorrhage or hematoma, which I said is usually completely harmless and takes about 10 to 15 days. It becomes from red to yellow and orange yellow, and then it goes away without leaving any scar, requires no treatment and never requires a drainage. So no incision and drainage or nothing. You just have to treat it symptomatically. Thank you.
Thank you so much, sir, for answering this question. We'll move to the next question for today's session. And the question is, which clinical findings suggest a dry eye syndrome etiology for red eye?
So if the patient has got occasional redness, not a continuous redness, and he finds that after working on the computer, towards the end of the day, the eye feels dry, or there is a poking sensation in the eye, or a sandy feeling in the eye, these point to dryness in the eye. Look for accompanying blepharitis and treat the dryness. You can treat with some tear substitutes available over the counter. But the blepharitis, as I answered in the last question, needs to be treated as well. Thank you.
Thank you so much, sir, for answering this question. We'll move to the next question and the last question for today's session. And the question is, which clinical findings suggest a Scleritis etiology for red eye?
Yes, so if the cornea is clear, but the white of the eye is inflamed, then you must suspect Scleritis, and these cannot be treated by family physicians. As I told you, some of these are life-threatening conditions. So I showed you some pictures of the Scleritis. You can get nodular, granular, or necrotizing Scleritis, and these are often treated with very severe immunosuppressive drugs like methotrexate and cyclophosphamide in conjunction with physicians. So they are to be taken seriously and referred to the eye surgeon. Thank you.
Thank you so much, sir, for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers who have joined our platform for this particular interactive session that has been conducted. And I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful inputs with our viewers. Thank you so much, sir.
Thank you. Thank you so much. Okay.
With all your last comments, sir, we can conclude the session here for today.